Good morning. Can you guys hear me? Let me open the chat. Yes, fantastic. All right, another day. Thank you so much for your patience. I had to move from yesterday to today. I'm going to get started momentarily, just giving a couple more minutes for the others to join. And in the meantime, I wanted to ask, how are we doing so far? Any questions about last week? I gave some exercises on WhatsApp, and I was pleased to see that everyone was participating and answering. I find it easier to give you a voting or questions with choices. It seems much easier to handle given the internet and the conditions. We will be also welcoming a few more of the students that joined last week. So whomever joined us and is listening to this in a recording time, welcome. This is the last of series, or close to the last of series, with respect to the conditions in which we examine the patients or we ask them. We will be moving to physical examination shortly, and we will be talking about tips and how to examine and so on. But today, it is my pleasure to start a presentation with respect to our, if I can find it, let's see if I can bring it up. Yep, here we go. And we're going to start the presentation here, and we're going to share. Please let me know if you are seeing the screen. I'm going to open the chat right here. And remember, if you wish to ask a question, you have either the reaction or the question, or you on the chat, or you can come off mute. So this is about taking a focused medical history, and I put in the event today the acronym, which is OPQRST, or old cards. These are various acronyms to make you remember the sections of each one of these, but you don't have to follow it. Eventually, you will not need any one of these because you will be a pro at this. So when we are discussing the focused medical history, it's when the patient comes through the door and you have already used a lot of the tips that we've used before, including how to take a um, how to initiate the conversation if the patient is upset, if the patient is quiet, if the patient is traumatized, if the patient is not even stable or awake, if they're not interacting with you. Those are some of the settings that we've used before. But today we're going to focus on the medical history itself. So when I was in your shoes, it's not the knowledge that we have or we think that we do not have. That's the struggle. The struggle is we teach you something in theory, and then you walk in the room, in the emergency room, and you don't know, it doesn't follow the same textbook. For example, you ask about chest pain, but the patient does not give you any of the chest pain that you remember from your books. So, how do you follow through with that? Additionally, when the patients talk to you, they start to jump from one place to the other. For example, they start to use vague words like, um, it, it's not pain, it's an ache, and you're asking, I don't know what does that mean, an ache. How do I ask about an ache? I don't know whether to ask, it does an ache travel? Does an ache stay in place? I don't know what are the circumstances. Well, yes, um, you're asking about ألم. وعم بيقول لك أنا ما بتألم بس بيوجعني. And they start to jump that the pain is accompanied by nausea, or the pain is accompanied by double vision, and you struggle to connect pain in the chest with double vision in the eyes. So how do you handle the real life scenarios? And that gap can always be connected by using some of the techniques. For example, we've used before the techniques of mirror and validate. The patient tells you, I have an ache, not a pain. And you say, you have an ache, it's not a pain. All you did was repeat it, but in a different tone. And that's very important because it's a human communication. And if someone was to repeat something you said, 9 times out of 10, you will continue to talk. Or, for example, if you validate. So, those are two things that I would suggest that you use often. For example, if the patient tells you, I have a pain, and you say, you have a pain, and it seems silly to you, and you feel like that's not appropriate. I need to say something else. So, what you say, that must be very difficult. And suddenly, because they're validated, they're going to try to tell you more. So use these techniques that we've talked before if the patient provides information that doesn't follow the textbook. Another way is when patients start to talk about things that are not related to the pain. For example, if they say, I have a pain, and then they start to tell you, yesterday I was in this neighborhood and then I moved to this neighborhood. And after that, somebody came to visit me because I was not feeling very well. Now, this is out of order. They're not talking to you about their pain until they finish it. And then they go talk to you about their history, their family history, or their circumstances. They jump from one thing to the other. It's your job to what we call refocus them. And we're all Arabs, and in our Arab diction and Arab language, we are polite. And in that politeness, we are taught without knowing certain techniques. For example, if someone were to tell you, and I was with my cousin and your cousin, and you can say at that time, you spoke about your cousin. Are there any other cousins or uncles, aunts that have diabetes? And now you yourself jumped into the family history.